works. So, to discuss this important topic, we have a very important eminent speakers on board. That is Dr. Subodh Chaturvedi. Sir has worked as a cardiac anesthesiologist for the 11 years, and for the past 5 years, he is working as a chief cardiac anesthesiologist at Nova Cardiac and Robotics, which is the highest volume cardiac center in Asia. He has conducted more than 4,000 cardiac surgeries. He is a technology enthusiast and has created the ISA national website in 2012, for which he has been awarded. He has also created website for ISA Indore and ISA MP. He is a member of Indian Resuscitation Council Federation since its inspection and worked in creating the online database and software system for the same. He runs an online education platform for doctors called as Clinical Guruji, and it has 40,000 plus students and counting. We welcome you, sir. And to moderate this session, we have another eminent stalwart faculty, Dr. Satyan Pareda. Sir is a professor and director, JIPMER, and he has experience of 20 years teaching and research. Clinical area of interest are cardiac anesthesia, critical care and trauma. His expertise is in advanced hemodynamic monitoring, echocardiography, and ultrasound application. He has also initiated DM program in cardiac anesthesia and currently serves as a course coordinator for the same. He has been honored with many awards, including section editor, Critical Care, Indian Journal of Anesthesia. And to his honor, he has IAC-IJ Best Review Award 2018-19, JIPMER Young Mind Award 2015, and he has many publication and research papers in index and international journals and many book chapters. Welcome, sir.
Thank you very much.
So now I request the chairperson, Dr. Satyan sir, to carry forward the session further from here.
Riddhima, just 1 minute. Just 1 minute. People are more than 500. So just tell anybody who wants to go to the class, they can go to the ISA NHQ YouTube channel because the capacity of the Zoom is 500 is already filled. Please, sorry for interruption. Now you please carry on, Riddhima.
Okay. I think we can start the session, Madam. Dr. Subodh. Dr. Subodh, sir, we can start.
Good evening, everyone. Am I audible? If I'm audible, just write
yes, sir.
in chat box.
Sir, but your voice is echoing. Your voice is echoing. Have you opened 2 devices? Subodh, sir, your voice is getting echoed.
Mere audible?
Try. I think it will be fine if it doesn't echo. Please go ahead. Please go ahead.
Can you hear us, Dr. Subodh?
मेरी आवाज ठीक से आ रही है तो एक बार यस कर दें.
सर इको हो रही है, आपकी आवाज इको हो रही है थोड़ी सी.
नहीं, मेरा डिवाइस कनेक्ट नहीं है. चेक करो. नहीं, मैं जूम पे नहीं हूँ. नहीं, बिल्कुल.
सर आपके 2 डिवाइस है क्या? That's why I think it is echoing.
I don't think you can hear us.
I think that's why the echo was there. But I think once it stops echoing, then the class will be very good. The problem is with the echo.
अभी ठीक आ रही है आवाज?
सर साउंड ठीक है अभी?
ठीक जा रही है.
आपकी पिक्चर नहीं आ रही है अभी, आप पिक्चर में नहीं हो.
अभी इको बंद हुआ क्या?
हाँ, इको बंद हो गया सर, इको बंद हो गया. या थोड़ा सा इसको साउंड को ज्यादा कर दो सर, लाइट थोड़ी साउंड की इंटेंसिटी कम है.
Am I audible now?
Sir, audible, but sound is little less.
ठीक है.
सर आप स्टार्ट कीजिए, बता देते हैं, आप स्टार्ट करके देखिए एक बार.
Fine?
Yeah, now it's fine. Please go ahead, sir.
शक्ल दिखा दे। अभी सब ठीक है? ऑडियो, वीडियो, बैकग्राउंड सब जा रहा है? अच्छा।
Manageable, sir, manageable. Please go ahead.
सबसे पहले तो I would like to say sorry for wasting everybody's like precious 25 minutes. मतलब वो जैसा सीता जी को लगा होगा ना कि धरती फटे और मैं उसमें समा जाऊं, आई एम एग्जैक्टली फीलिंग लाइक दैट। आई एम रियली सॉरी फॉर दिस ऑल डिले। आई होप आई मेक इट अप टू यू पीपल। Thank you so much for patiently waiting for me. I would like to thank at the outset to the ISA National, Naveen Malhotra sir and Sukhminder sir for providing me with this opportunity to present this lecture in front of you people. I mean, this platform has been decorated by stalwarts, big anesthesiologists, people whom we used to admire. And today I'm standing on this platform and I'm presenting to a national audience. I'm really honored. It is almost like giving a CME lecture in a national conference. So thank you so much, sir. And I hope and I promise I'll try my best to make it up to your time. So right now we'll begin at the outset. ECG for exams or ECG in itself for especially an anesthesiologist, it is a confusing thing. You keep looking at it, but it's like difficult to interpret. We don't know what to look at. We don't know what to guess out of it. Then we start learning from Shamroth, and then we go into sodium channel, potassium channel, slow channel, fast channel, and things go haywire. So before I start, I would give a very quick disclaimer. Nobody can teach ECG in an hour's time, in 2 hours time, in 10 hours time. I have been learning so far. My seniors have been learning and you are learning. Everybody has his own journey. But yes, what I can promise you is that after this 1.2 hours, you will be way better than what you started with. At whatever level you are, you will be definitely better than what you started with. Secondly, this is just a last moment effort to pass the exam. I'm not teaching you ECG from beginning to the end. I'll just give you some quick tips and tricks, some nuskhe, some jugade, so that you can clear the exam, so that your examiner knows that yes, ye marega nahi patient ko. Thirdly, this is going to be an interactive discussion. At times you'll have to write in your chat boxes. At times I'll just unmute everyone and you can just shout on your microphones. So let's do a quick experiment if this chat box thing is working. Just a quick MCQ. Who is this guy? Write in the chat boxes so that we can just get familiar with the system. This whole webinar will work like that only. I'll keep asking, you'll keep answering. Who's this guy? Right. Chalo. So everybody thinks he's Einthoven because he's not Beethoven. He doesn't look like my grandfather. He is none of the above. He's Wilfredo Pareto. And what Wilfredo Pareto said was a beautiful thing. He said that 80% of the results you get in your life, whatever you do, they come from 20% of your efforts. Like you do a PG for 3 years, but you actually study for exams for 6 months and you clear the exam. That is how life works. Whatever you do in your life, only 20% of efforts are the ones which actually give you results. This Pareto principle works everywhere. 20% of people control 80% of economy of India. Right. So what I'm trying to do here is I'll teach you the 20% things that will probably give you 80% chance of clearing the exam. So another disclaimer, if you are aspiring to be a university topper or something big, then probably this lecture is not for you. This lecture is for the basic, average, PG, one who hasn't studied for long and he just wants ki Bhagwan bas pass kara de. This lecture is for those kind of people. Your examiners are also very smart. They know, they can see your brain. They know how much depth you have. They know ki tumko kitna aata hai. And they don't want to test ki if you have read Shamroth or not. They want to test only 2 or 3 things. First thing they want to test is ki will this guy kill his patient on the table? Will he be not able to recognize a ventricular tachycardia and his patient will die? Secondly, what they want to know is that can this guy properly triage a patient, properly decide that yes, this patient needs a cardiac call and this patient needs an echo, or this patient might need an angiography. So your examiners know you well. They know that you have seen the ECGs. They know that you remember ki lal wala is VT and hara wala is VF and jis pe chai giri hai wo atrial fibrillation. They want to check, can you kill a patient on table? Can you choose this patient has to be shifted for cardiac evaluation and this one is not? And then if you pass those two tests, then they see if you are worth the gold medal of anesthesia or not. Now, I expect that there will be MDs and DNBs appearing, and a lot of focus nowadays is on OSCEs. So I will try to teach it both ways, because in MD exam, in a Viva, you present a ECG in a typical classical way. So I'll try to cover a minute about that, and then we'll jump to the diagnosis part. So the classical way of explaining an ECG, if you get an ECG in exam, is that you have to describe the ECG. Even if you know the ECG. See, in every college, in every hospital, you know the ECGs beforehand. Your seniors show you, your APs show you in the pre-university and everywhere. So you know कि कौन से ECG में क्या है. But then don't show that to your examiner. Pretend that you are reading it actually for the first time. So say, so this ECG is properly standardized. The axis is normal, the rate is this much, even if you know the diagnosis beforehand. So you have to explain it this way. So let's start. First of all, when you see an ECG, you have to see and you have to tell if the ECG has a normal standardization. Now, don't worry. All the ECGs, most of the ECGs, 99.99% ECGs of every hospitals are standardized normally. So all you have to see is that, yes, this box before the QRS begins, before the ECG even begins, this comprises of two big boxes. This is one big box and this is second big box. This standardization thing covers two big boxes. That's all you have to check, and don't even need to check it. Just say that the standardization is normal. They won't be putting half standardized or double standardized ECGs for you like this. They will be putting a normally standardized ECG. What is normal standardization? How much? 1 millivolt is equals to how much? Chodo, 10 mm. Then you'll say that standardization is okay. Now I'll go for axis. So in axis, again, you don't need to calculate exact axis. All you need to see is if the axis is normal, left deviated, or right deviated. That's it. Again, how do you check axis? Very simple. Just look at two leads, lead 1 and lead AVF. If lead 1 and AVF both are pointing upwards. What does it mean by pointing upwards? If both QRSs are pointing upwards, then you can safely say that the axis is normal. Again, 1 and AVF. If both are pointing upwards, the axis is normal. If the leads have their QRSs ulta, if they have their QRSs going away from each other, then you can say that it is left axis deviation. Left leaves and right reaches. You have all read this before. I'm just rushing through this. So 1 and AVF, both upright, axis is normal. If they are going opposite to each other, left axis deviation. If they are going towards each other, then it is right axis deviation. Right reaches and left leaves. Just like that in the diagram. The normal axis, 1 and AVF, both QRS pointing upwards, 1 and AVF going away from each other, left axis deviation, and right axis deviation, they are both trying to reach each other. Done? Let's go again. So in exam, you have to first attempt the ECG in 3 steps. In first step, you need to first make sure that you are not getting failed. Second step, you have to make sure that you get some marks. In third step, if you survive, then you have to go for the gold medal. So first, you cannot miss on rate and rhythm. That is a must. Then in second step, you have to check for hypertrophies and ST segments. And thirdly, in gold medal, there are some complicated things which will come at the end of this lecture. So before we start learning rate and rhythm, let's go through some absolute basics in a very stupid kind of system. We call it uncha uncha, bada bada, fast fast. Let's understand. PQRST you all know. I'm not going to teach you that P wave is atrial depolarization, then QRS is ventricle, then T wave is ventricular repolarization. You know that. You know that PR interval is the impulse is stopping at AV node for some time, and you know that QRS duration indicates the conduction in the ventricles. You know all those things. So let's not go there. What I'm trying to teach you is something different. You have to learn कि if it is uncha uncha, then the ventricles are big. If they are pass, then the rhythm is fast. If they are dur, then the rhythm is slow. If the changes are in the right leads, then they are right-sided. If they are in the left leads, then they are left-sided. That sounds stupid, no? Let's understand. Your ECG is just like a graph paper. That means you must have seen graph papers in class 8th, 10th, whatever. Every graph paper has an x-axis and a y-axis. X-axis is for constants and y-axis is for variables. Constant means which doesn't change with time, and variable is the thing which changes in respect of constant. What two things do we plot on an ECG graph paper? Can somebody tell me in the chat box? What two things do we plot on an ECG graph paper? What do we plot? Not amplitude, not amplitude. We plot two things. One is voltage and the other is time. So we plot voltage against time. That means anything which is on y-axis, anything which is vertical is voltage, and anything which is horizontal is time. Fair enough? So now time to unmute when I ask, right? So let's see. There are two waves. One is this wave and one is this wave. Now we learned that anything which is uncha uncha is big. Big means high voltage. Anything which is tall on y-axis has high voltage, and anything which is small on y-axis has low voltage. So out of this blue and green, which one has higher voltage, blue or green? Unmute. Just unmute your mics and start shouting. Which one has higher voltage?
Green.
Blue or green?
Green.
Everybody is saying green. Of course it is green. The thing which has higher voltage is green. That's easy. Let's complicate it a little. Again, there is blue and there is green. This is your P wave and this is your QRS complex. Which one has higher voltage, P wave or QRS complex? Shout out. Shout.
Everyone
Which
is
one?
writing green QRS.
Yes. So QRS has higher voltage, right? Why? Because P wave is generated by atria and QRS is generated by ventricle. Atria are like thin bed sheet like things, and ventricles are thick mattress like things, right? So P wave, it is because of depolarization of atria, has a small voltage, and QRS complex, which is because of the ventricles, has higher voltage. This leads us to mute kar do. This leads us to another step. If it is tall, then it has higher voltage and it has more muscle mass. Ventricle ka muscle mass is more than atria ka muscle mass. Anything which is tall has more muscle mass. So more voltage is equal to more muscle is equal to hypertrophy. That means if P waves are taller than normal, then it is atrial hypertrophy. And if QRS complexes are taller than normal, then it is ventricular hypertrophy. Easy, na? Wait. Vertical is voltage. Small voltage, small size. Bigger voltage, bigger size. P waves are small because atria are small. If P waves become tall, that means atria are getting hypertrophied. If QRS complexes become tall, it means that ventricles are getting hypertrophied. So in this ECG, you can see the QRS complexes in V1, V2, V3, they are so tall that they are going into each other. They are pinching each other. V4, V5, V6. Why are we talking about V1, V2, V3? Because they are the chest leads. They are the precordial leads. They show you the ventricles. The ventricular muscle mass is shown by chest leads. V1, V2, V3, V4, V5, V6. Right. So if these QRS voltages are high, if these QRSs are tall, then what is this? This is ventricular hypertrophy. Agreed? What if the QRS voltages are small? What say this is so small, so small, so small, so small. What does it mean? Is it ventricular hypotrophy? Have you heard ventricular atrophy or hypotrophy? What is it? Can you write in the chat box? If the QRS complexes are small, then what does it indicate? ECG legend को तो आता ही होगा भाई. It is low voltage. Why low voltage? Because of pericardial effusion. Right? When the complexes are small, it doesn't mean that the ventricle has shrunken in size. It means that there is some insulation between the ventricle and the chest wall. That insulation could be a lot of air, as in emphysema. That insulation could be in the form of fat. Some very obese people tend to have small QRS complexes, and that insulation can be in the form of pericarditis or pericardial effusion, some fluid between your heart muscle and your chest wall. Got it? So if it is tall, then it is hypertrophied. If it is short, then it is not hypotrophied. It is something like some insulation between the two. Yahan tak samajh mein aaya? If it is Aya, then just write Aya in the chat box. So we can go on to the next part. Aya. Good. ठीक. So we heard कि if it is ऊंचा, then it is बड़ा. If QRS complexes are tall, then the ventricles are enlarged. और एक बात यहीं सिखा दूं. Your V1, V2, V3, V4, V5, V6. 6 chest leads. These two indicate the right ventricle, V1 and V2. The last two, V5, V6, they indicate the left ventricle. V1, V2 right, V5, V6 left. Just direction. So if the QRSs are tall in V1, V2, then it is right ventricular hypertrophy. Usually QRSs are negative in V1, V2. But if QRS is tall in V1, V2, then it is right ventricular hypertrophy. And if QRSs are tall in V5, V6, very tall in V5, V6, then it is left ventricular hypertrophy. So tall is hypertrophy. On the right side, it is RVH. On the left side, it is LVH. Let's go further. So ECG graph paper is horizontal and vertical. Horizontal is time, vertical is voltage. We learnt about the voltage part. Now, if something is close on the horizontal axis, if things are crumpled together, if things are very near, then it means that it is fast. If things are far apart, then it means they are slow. So these are hearts, they are at some distance, and these are smileys, they are at some other distance. Which one is faster, heart or smiley? Write down, or maybe just shout. Just shout, unmute and shout.
Smile.
Smileys are faster. Right. So everybody knows that smileys are faster. Why? Because they are nearer in the, remove the chat box. They are nearer on the horizontal axis. Now this horizontal axis is very beautiful to remember. One box, 300 carat. Two boxes, 150 carat. Three boxes, 100 carat. Four boxes, 75 ka rate. 5 boxes, 60 ka rate. So if the smileys or QRS complexes are 1 box apart, the rate is 300. If they are 2 box apart, the rate is 150. 3 box apart, 100. 4 box, 75. 5 box, 60. Beyond 5 box, it is bradycardia. Below 3 boxes, it is tachycardia. So smileys are faster. Once again, we'll try. This is the pink wave and the other one is the green wave. Just shout which one is slow and which one is fast. Easy, easy. Which one is slow, which one is fast? Pink one is fast. Green is slow, contrary to what we believe. Right. So, yahan tak to sabko sab aa gaya. So, narrower the gap, faster the event. Nearer the waves, faster the rate. What does it mean? If the QRS complexes are very near to each other, the rate is very fast. If they are like 1 box apart, it's 300. 2 box apart, 150. If the gap between 2 waves, like P wave and QRS wave ke beech ka gap, if that gap is narrow, then it is fast. Fast, matlab, see, PR interval is short if the gap is narrow. PR interval is wide if the gap is wide. It's easy. So if the gap is narrow, the event is fast. If the waves are nearer, the rate is fast. Let's say this one. This is ECG F. ECG F has QRS gap of how many boxes? 1, 2, 3, 4, 5, 6, 7. So this is definitely a bradycardia because the number of boxes is higher than 6. Got it? Jitna dur, utna slow. Pass, pass, fast, fast. Slow, slow, dur, dur. So if they are far apart, it's slow. If they are very near, it's fast. So this one is slow. Why? Because the gap is more than 6 boxes. This is bradycardia. This one is fast or slow? What is the rate? Can somebody write the rate in the chat box? Can somebody write the rate in the chat box? Wonderful, 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 wonderful audience. Very good. So now you know fast and slow, you know the rate. Okay, which one of them has a high PR and which one has short PR? Which one is short PR? Green or red? Which one is short PR? Short is green, green, green. Good, good, good. Perfect. So we understood that we have to talk about standardization, we have to talk about axis, then we have to talk about rate and rhythm. So rate we discussed. Rate we discussed, if it is more than 6 boxes, you don't have to be specific. They are not going to count with you. You have to say that the rate is approximately 75. Then you have to go for rhythm. So we understood this part. Aage chalte hain. So when you describe or understand rate and rhythm, you have to say if it is fast and or slow, if it is broad or narrow, if it is regular or irregular. So you have seen the ECG, you have seen that it is fast or is it slow. Now you have to judge if the QRS complexes are broad or narrow. So very quickly we'll analyze a few ECGs. This one is fast or slow. This is slow. Why slow? Unmute कर दे, जल्दी जल्दी हो जाएंगे. हाँ. So
It is
slow. Slow. Sudur, what is the rate? Rate.
Regular.
Slow.
Rate. Calculate. 1, 2, 3, 4, 5, 6, 7.
42.
Less than 60, approximately 40. Got it? Slow. This one is
Fast.
fast. What is the rate?
Tacky.
Approximately.
What is the
More
rate?
than 150.
More than 150.
More than 150. Quick. Chalo, agla.
Narrow.
What is this?
Fast.
Fast or slow?
Fast.
What is the rate?
150.
150, 200. Good, good, good,
More
good.
than 150.
More than 150. Good. This one is
Slow.
slow. What is the rate?
Less than 60.
40.
Less than
Less than
60,
30.
approximately 40.
40.
This one,
Low.
Slow. Slow.
Less than
Slow.
40.
Less than
who said
60.
fast?
Slow.
Less than 40.
Less than 40. This one,
Slow.
this is not a QRS, huh? This is not a QRS. This one is again slow. So
Very
slow
slow.
and fast, you know. Right. This one is
Very fast.
very fast.
Very fast.
This one,
Normal.
this one is sadism. If somebody gives it in your exam, they should be asking tachycardias and bradycardias. If somebody gives you a normal rate, then it is cheating. Chalo, mute. So we checked. So we checked if the rate is fast or slow. Now we'll see if the QRS complexes are broad or narrow. How will we see? We have to check the width of the QRS at the waist. What is the waist? Waist means this is your TP line or your baseline. T to P, this is your baseline. You have to check the width of the QRS at the level of baseline. If it is wide or if it is narrow. QRS should be how much? Less than 3 small boxes. 3 small boxes, 0.12. So if the QRS is broader than that, we won't even count. We'll just see. If it is broader at waist, then it is broad QRS. If it is narrow at waist, it is narrow QRS. So for in this example, the upper one is narrow QRS. It is narrow at waist, hardly 1 small box. And this one is broad QRS. This is kind of 3 or more than 3 small boxes. This is broad QRS. So narrow, broad, narrow, broad. What is this? Broad or narrow? Write down. Write down or speak? Kya kare? Write down. Write down. This is broad. Broad. Good. What is this? Broad or narrow? You have to check the width at the waist, at the baseline. At the baseline, it is broad. Right. This one, there is no baseline visible, but whatever it is broad. Right. Then this one. What about number 6? Number 6 is what? 6 is narrow. Good. 7 is again narrow. So now we know how to talk about standardization, axis, rate, and width of QRS complex. Now we have to see if the rhythm is regular or irregular. Hata the chat box. If the rhythm is regular or irregular. How do we see that? If the QRS complexes are at equal distances, then it is a regular rhythm. If the QRS complexes are at irregular distances, that means 2 or 3 are clumped together, a few are far apart, then it is irregular rhythm. So this one is irregular. Why? These 4 are coupled, then a gap, then these 3 are coupled, then 2 are even nearer, then it is far apart. This is completely irregular rhythm. Right? A is irregular. B is narrow QRS, fast and regular. See, this gap is equal. Everywhere you check, this gap is equal. So, narrow QRS, regular, fast. This one is narrow QRS, irregular and fast. This is irregular. Why irregular? These few complexes are crumpled together. These QRS complexes are far apart. So if you calculate heart rate at this point, it will come to be like 150, 200. If you calculate here, it will come like 100 or 75 even. So this is irregular. This is again irregular. So now we have got three features of a rhythm. If it is fast or slow, if it is broad QRS or narrow, if it is regular or irregular. So with these three things, if we make a box, we can make 9 rhythms, but we will make 6 most common things. If the rhythm is fast, broad and regular, if the rhythm is fast, narrow and regular, if the rhythm is fast, narrow, irregular, slow, broad, narrow or regular, no, narrow or irregular. Correct? So now we'll explain every rhythm in this format. So I'll put up an ECG in front of you and you will answer if it is fast or slow, if it is broad or narrow, if it is regular or irregular. So what you have to do in the chat box is you have to write it as, let's say this will be ECG number 1. So you will write 1 is dash F, fast, B and R, fast, broad, regular. Or if it is irregular, then that way. So here is the first ECG coming to your screen. What is this? You have to write just short forms. This is FBR, fast, broad and regular. Fast, broad, regular. FBR, fast, broad, regular. So just remember, if the rhythm is fast, broad and regular, it is a ventricular tachycardia. And for an exam, you cannot miss this. If you miss this thing, then you deserve not to pass. So this rhythm you should identify, happen whatever may. You might misread a SVT with aberrant conduction as a VT, that is okay. But you cannot miss a VTAC. It is broad, fast and regular. Again, this one, broad, fast and regular. No, this is irregular. So first one was what? Fast, broad and regular. VTAC, cannot miss a VTAC. Second one is fast. You can see fast. How fast? Because these two QRS, they are even less than one box. That is faster than 300. So this is fast, broad. But is it regular? Is it regular? No, it is irregular. So this is fast, broad, irregular. This is ventricular fibrillation. Got it? Now, your examiner needs to know 2 things from you. A, he needs you to identify, because in an OT, anytime the patient might go into VTAC or VFib. He needs to know if you can identify the rhythm, and then he would ask, how will you approach it? So let's say if you see this rhythm on your monitor, describe it. Is it FBR? Is it FBI? What is it? What is this rhythm? This one. What is it? Fast, broad, irregular. Regular ki irregular? So is it VT or is it VF? Right. And what will you do if you see this rhythm? Will you give shock of 200 joules or will you give amiodarone? What will you do? Shock or amiodarone? So now that is what you need to know. Hata do. Bhaiya, this happened in my OT only. My technician came to me rushing. Sir, VT ho gaya. Fine. Just see. This is absolutely normal pulsations of saturation. If your patient is having a VF, then this cannot be true. So whenever you find a patient with a bad rhythm in your ICU, in your OT, the first thing you need to check is pulse, carotid if possible. If the head is covered, then maybe you should go for radial or something, preferably carotid. And it's not always a ventricular tachycardia or ventricular fibrillation. Even the algorithm says that when you see a broad complex tachycardia or something, first you check the pulse. If it is with pulse, then you have to go for medications. If it is without pulse, then you have to go for something else. So this patient had basically a lot of betadine, and the electrode was removed. The moment the electrode was placed again, it was all normal. So if the rhythm is fast, broad, and regular, or for that matter irregular, you have to check the patient if there is a pulse or not. Then you have to decide if the patient is pulseless and you see a broad complex rhythm. The first thing you need to do as per ACLS protocols is shock. Shock of how many joules? 200 joules if you have a biphasic defibrillator, 360 joules if you have a monophasic defibrillator. No confusion. The highest number of joules on your machine you have to shock the patient with. Got it? Chalo. So we have learned fast, broad, regular SVT. We have to check pulse. If it is fast, broad, irregular, most likely it is VF. It will never have a pulse. You have to shock it. Then what is this? Is it, what is the rhythm? Classify it. Is it FVR? What is it? FBI, FBR. This one is fast, narrow, and regular. Right. This one is fast, narrow, and regular. This is a supraventricular tachycardia. How do you identify it? The supraventricular tachycardia is fast, very fast. Usually supraventricular tachycardias are faster than 180, mostly faster than 200. So if your patient is having a regular rhythm of 200 or 189, then most likely it is SVT. The thing, this looks like a P wave. It is not a P wave. It is the T wave of the previous complex. So fast, narrow, and regular, more than 200 ka rate is usually SVT, supraventricular tachycardia. Now, I will not digress into the multiple types, ki AVRT and AVNRT and junctional tachycardia. If you just simply diagnose it as SVT, believe me, nobody is going to fail you in the exam. Right? Again, they just want to make sure that if you can identify it as an SVT, supraventricular, all these AVRT, AVNRT, everything is supraventricular only. So all they want to know is if you can identify it and if you can treat it accordingly. If it is SVT and if it is SVT with the patient in shock or hypotension or failure or something like that, then you might give a defibrillation or cardioversion. Or if it is stable, then you might give adenosine or whatever. So they want to go for the treatment part. You have to just make sure that you identify the rhythm correctly. It is fast, narrow, regular, without P wave present, usually faster than 180 degrees. This is supraventricular tachycardia or SVT. Abhi tak sab theek aaya? If it is aaya, then likho aaya. Then we will see the next rhythm. Oh, isme to number naam already aa gaya. Chalo. Chalo, haan, isko chat box ko rehne dena. So this one is fast, narrow, and irregular. P wave is not visible. Fast, narrow, irregular. P wave is not visible. What is this rhythm? You tell me, what is this rhythm? No, not PSVT. This is atrial fibrillation. So what is the most common arrhythmia in the OT? What is the most common arrhythmia in the OT? Batao. The most common arrhythmia in the OT is sinus tachycardia or sinus bradycardia. The next most common is atrial fibrillation. The second most common arrhythmia is atrial fibrillation. In ICU again, atrial fibrillation is one of the most common arrhythmias, other than the sinus tachys, of course. So this is fast, narrow, and irregular. It is atrial fibrillation. How is it identified? It is irregular. It is not necessarily fast. If your patient has atrial fibrillation and it is treated, so don't expect always that atrial fibrillation will have a rate of more than 100 only. At times, the patient is having Cordron or some beta blocker or something to control the rate. And sometimes the atrial fibrillation might be having a rate of like 70, 80, 100. But mostly If it is occurring in the OT randomly, then it will be fast AF only. So we can say that atrial fibrillations can be a fast AF or slow AF, or sometimes they call it AF with fast ventricular rate and AF with slow ventricular rate. But again, so you need to identify these 4 rhythms in the first place. First one is VT, broad, fast and regular. Second one is VF, broad, fast and irregular. Third one is SVT, narrow, fast and regular. Fourth one is atrial fibrillation, narrow, fast and irregular. Now what is this? Explain. Again, don't diagnose it. Just write if it is fast or slow, if it is narrow or broad, if it is regular or irregular. Write down. Okay, which is shockable, VT or VF? If pulseless VT, then shock. If VF, then shock. This is slow, broad, and regular. Slow, broad, regular. Right. Now, again, just remember, what is the rate? Can somebody tell me the rate? If I go and calculate, it will be very slow. 1, 2, 3, 4, 5, 6, 7, 8 almost. 300 divided by 8, 35, 40 ka rate hoga iska. Right. So this is slow and regular. If your rhythm is slow and regular, then it is most likely, believe me, it is so easy to diagnose. How we try to learn complete heart block has a complete AV discordance and the P waves are not in unison with the QRS complexes and the, I don't know. Very simple. If it is slow, 30, 40 ka rate and regular, most likely it is complete heart block, especially for the exam purpose, just go with complete heart block. Complete heart block is slow and regular. It could be narrow, it could be broad. If it is a ventricular escape rhythm, it will be broad. If it is a junctional escape rhythm, it will be narrow, but let's not go there. If it is slow, and slow means not 60, slow means 35, 40. If it is slow, regular, and irrespective of broad or narrow, it will be complete heart block. You are getting me so far? Slow, regular is complete heart block. Okay. Agli rhythm. Describe. Describe. Chat box. So this is again slow. Not exactly slow, but yeah, slow. You can say average heart rate nikalenge, so it will be slow. Narrow and irregular. Slow, narrow, and irregular. Average heart rate will be like less than 65, 70. Slow, narrow, and irregular. This is again second degree AV block. I'm not going into Venki back or Mobitz type 1 or type 2. You just go with second degree AV block. Like I said, this class is not for toppers. This class is for people who just want to pass their exams. This is slow and irregular. It is second degree heart block. How do you identify second degree heart block? It has grouping of QRS complexes. Like few QRS complexes will be grouped and then there will be a gap. See here, like 3-4 complexes are grouped, then there is a big gap. Then there will be clumping of complexes, then there will be big gaps. So there will be chunks of QRS complexes lying in the picture. It will not be slow and regular. It will be slow and irregular. So we are not talking about Mobitz type 1 or type 2. Of course, I can teach you, but let's keep it simple. This is slow and irregular. That means it is second degree heart block. Right. So they just want to ask you a few things. Which heart block is bad? Is it first degree or second degree or third degree? Third degree is obviously the worst. Second degree is something which can quickly degenerate into complete heart block. So second degree needs to be treated. If the patient is like unstable, You might want to give shock. No, you might want to give atropine, or you might want to start pacing, or you might want to start dopamine infusion, or you might want to start epinephrine infusion. Just go with your ACLS algorithms. Right. So we have learned 6 rhythms so far, and that's what I promised. First is VT, fast, broad, regular, FBR, VF, FBI, fast, broad, irregular, AF, fast, narrow, irregular, SVT, fast, narrow, regular, और क्या बचा? Slow and regular is CHB, and slow and irregular is second degree heart block. Believe me, don't even believe me, believe Pareto principle. 80% of your ECG rhythms will not go beyond this. Then your examiner wants to know if you can identify the rhythm. Then maybe he would like to go for something bigger. He would like to check if you can postpone a case or not, depending on ischemia or infarction. Again, the ECGs kept in the exam. This lecture is specifically for exam-related ECGs. If you want to learn someday how to handle ECG rhythms and everything, that I'll teach somewhere else. How to read an ECG in an OPD. I have a video on YouTube. You can find it there. Anyway, in exam, they will keep like gross findings. They will not keep subtle findings. Ki thoda sa ST elevated. No, they will keep big ST elevations. So your examiner wants to know which cases you can postpone. So you will further investigate. You will look for ST segments. And the first lead in which you will look for ST segment is lead 2. So once you have went for the rate and rhythm, the next thing you will check is lead 2. If your lead 2 has an ST elevation as this one has, then you will look for 2 other sisters. If your lead 2 has ST elevation, then you will look for 2 sisters. Which ones? Lead 3 and lead AVF. If all the 3 have ST elevation, then you can safely say that, hey, sir, this is inferior wall MI. It could be ischemia if it is depression. Again, I'll try to keep the class simple just to pass the exam. एक बार pass हो जाओ, फिर detail में पढ़ेंगे. So you have gone for rate and rhythm. Then you check, the first lead you check is lead 2. If lead 2 has ST elevation, then you look at lead 3 and lead AVF. You have to get the signature of 2 witnesses, like in every government function. You have to bring 2 gawah. So if lead 2 says that I have ST elevation, you have to bring two witnesses, lead 3 and lead AVF. If both the witnesses say yes, there is ST elevation, then you will say yes, this is an inferior wall MI. What if lead 2, 3 and AVF don't have ST elevation? Then you will look at the other set of leads, that is V1 to V4. इसमें तो वहां भी है. So in this ECG, I guess this is a little blurred, but then in this ECG, lead 2 and 3 don't have big ST elevations. So you look at lead V1, V2, V3, V4. All of them have big ST elevations. You know how to check ST elevations? ST elevation means that there is a thing called as J point. J point matlab, when the QRS ends, that point is called as J point. If that J point is higher than the baseline, then it is ST elevation. If that J point is below the baseline, what is baseline? Though QRS complexes ka gap is called as baseline. Well, I'm trying to teach too much in an hour, but then this is your baseline and this is your J point. If your J point is well above the baseline, it is ST elevation. If your J point is way below the baseline, if it was like this, then it will be ST depression. So you have seen lead 2, 3 AVF, 2, 3 AVF are normal. So you go to lead V1, V2. And if these leads have ST elevation, you check for 2 more witnesses, V3 and V4. If they all have ST elevations, you can safely say that it is an anterior wall MI. I had given a PDF, if you remember. It has 3 pages. One is for tachycardias. There is an algorithm. There is a cheat sheet. There is an algorithm for bradycardias. And then there is a anatomically contiguous leads chart. So you can just, they are color coded. You can just remember 2, 3 and AVF are inferior leads. 1 AVL, V5, V6 are lateral. V1 to V4 are anterior leads. Just cram it down for a while. Then slowly when you start reading ECGs, it will come naturally to you. So yeah, V1 to V4 are having ST elevations and these are anterior leads. So this is an anterior wall MI. So two things can happen. Either it will be an anterior wall MI or it will be a inferior wall MI. Thirdly, it could be a non-ST MI or ST depressions or T inversions. So your exam ECG might have. Now you have seen the rate rhythm, you have described it. Then you have seen the second, third and AVF, they don't have big ST elevations. Now you go for V1 to V2. V1 is okay, there is no ST elevation, but V2 is starting to have a deep T inversion. V3 has even deeper T inversion. V4 has even deeper T inversion. This is a non-ST elevation MI. How will you diagnose it? You will diagnose or you'll confirm an STEMI with a trop T or trop I. ठीक? तो हमने ECG में standardization देखा, फिर axis देखा. Then we went for rate, rhythm. Rhythm we have identified. We have identified 6 most common possible rhythms. Then we have gone into ischemia part. We have seen lead 2, 3, AVF. If they are normal, then we went for lead V1 to V4. If they had ST elevation, then it was anterior MI. If they had ST depressions or T inversion, then it is an N-STEMI or non-ST elevation MI. Then we look for some other things. Again, this ECG might be a little blurred for you. But then what you can appreciate here is a very tall T wave. This is again a favorite ECG in exams. Tall T waves. What does tall T wave indicates? Write in the chat box. What does a tall T wave indicate? Likho. A tall T wave indicates two things. A tall T wave indicates either it is hyperacute changes or developing anterior wall MI, or it is a hyperkalemia. Either it is hyperacute changes. Matlab, hyperacute changes means the MI is just about to develop. So the first thing that happens is not ST elevation, it is tall T waves. Otherwise, the other possibility is hyperkalemia, but hyperkalemia T waves are like pinching. If you put your finger, it will get pinched. So this T wave is more likely to be, I cannot say absolutely, but this T wave is more likely to be hyperkalemia than a acute MI. Right? So far, so good. If you have gone through your Viva and you have answered all this, then you are already cleared. You are one of the better students. Then comes the time of diagnosing a few difficult ones. So I will not again teach you 10 different ECGs. We have hardly 5-10 minutes left. So 2 or 3 things I'll teach you quickly. Other than that, beyond that, you can just write in the comments in the YouTube video when ISA posts it, and I'll try to answer it there. So identify this wave. Identify this wave and write down. Maybe we can do it as an homework. What is this? क्या बात है? Homework की जरूरत ही नहीं पड़ी. Good. This is delta wave. I won't go into much details. This is narrow PR and like early pre-excitation. ठीक है. Then these 2 things you need to know. So we have learned that if it is uncha, then it is hypertrophied. If it is broad, then it is slow in conduction. Right? Now 2 things. You have all heard about M pattern. Again, these blocks are way more complicated than that, but let's try to simplify them for now. This is M pattern, 2 ears of a rabbit. This M pattern is in lead V1 and V2. we had discussed that right is right and left is left. V1 and V2 are right-sided leads. So if anything goes wrong with them, then it is right-sided. If QRSs are tall in V1, V2, it is right ventricular hypertrophy. If QRS is tall in V5, V6, it is left ventricular hypertrophy. Similarly, if there is an M pattern in V1 and V2, it is right bundle branch block. And if it is M pattern in V5, V6, then it is left bundle branch block. It is that easy. You have to just get a hint. So this is M pattern in lead V1 and V2. And remember, in exam, they will be gross only. This is M pattern in V1 and V2. This is right bundle branch block. So look for M patterns. If they are in V1, V2, it is right bundle branch block. And if they are in V5, V6, then it is left bundle branch block. Got it? Left bundle branch block is like one of the most difficult ECGs, especially when you are new in the ICU and something, no? And the patient comes and he brings an ECG which looks like a VT, and the patient is sitting all normal in front of you. So the thing which looks like a VT, but it is like 70, 75 cardiac patient is absolutely comfortable. Broad QRSs, they all look alike. The whole ECG looks like same. This is left bundle branch block. So if you see an ECG and you see ye kya hai, then it is mostly left bundle branch block. So to summarize, first of all, we have to look the ECG in 3 steps: rate, rhythm. We have learned 6 probabilities. Then we have to look for ischemia and MI. Again, not much in depth: inferior wall, anterior wall, and L-STEMIs. Then we have to become like good children and we have to look for M patterns, W patterns, delta waves. So this lecture ends here. Would anybody want to learn a little more? 5-10 minutes more? अगर चाहे तो लिख सकते हैं continue. So I can wind it. I mean, this is my last slide. Okay. So you're not getting tortured, right? So ठीक है. Now I won't teach you much. I will ask a few questions and you answer me. After all, it is exam. Right? So you will describe the ECG and then you will diagnose it. So you'll write, this will be like question A, and you will write A is equal to fast, narrow, regular. This is SVT or whatever. Write down. Give me a diagnosis. But don't diagnose it. Write it down. What is this? If it is fast, narrow, regular, what is it? Good. Fast, broad, regular. And what is this fast, broad, regular? What is the diagnosis? Diagnosis, diagnosis, diagnosis. So your diagnosis is correct. Good. आगे चलते हैं. This is ECG B. Diagnose it. So explain what is it. But just don't jump with the diagnosis. Huh? Write down. Fast, narrow, regular, SVT. How will you treat SVT? If it is stable, then I will go with adenosine. If it is unstable, then I will go with synchronized cardioversion. These are 2 most asked questions. If it is SVT, how will you treat it? So if your SVT is stable, if your patient has a BP of like 90/70 or something, he's fine, then you will treat it with adenosine. If your patient is unstable because of SVT, right? If your SVT is causing hypotension or failure or unconsciousness, altered sensorium, then you will treat it with synchronized cardioversion. How will you do synchronized cardioversion? We'll put the paddles on the chest of the patient, we'll sedate the patient, and we will mark the QRS complexes with a dot. the defibrillator already does it by itself. And then we will start with a shock of like 50 or 100 joules. That's how you treat a SVT. Then what is this? I haven't taught it in the class. You just explain it. Don't give me a diagnosis. You just explain it. Is it fast? Is it narrow? Is it regular? Is it irregular? This is fast, narrow. Is it irregular? No, it is not irregular. We check the regularity with the gaps between QRS complexes. The QRS complexes are best seen here. Jitna yahan gap hai, utna yahan hai. The gap is equal. You see this gap. This is equal to this, is equal to this, is equal to this. This is regular. So this is fast. Not exactly fast. This is 75 ka rate mostly. 4 box hai na? 1, 2, 3, 4. So this is not fast, but okay, we can classify it fast, narrow, regular, but with multiple P waves present. This is again a favorite ECG of exams. You hardly ever get to see atrial flutter in real life, but you see a lot of it in your OSCEs and your exams. So multiple P waves, sawtooth appearance. Nobody, I mean, I don't think your generation might have seen a saw, RE. So this has a sawtooth appearance. This is an atrial flutter, right? How will you treat atrial flutter? I mean, you will hardly ever get to see it. Again, the principles are same. If it is stable, then drugs. If it is unstable, then shock. Now, what is this ECG? The rate is normal. Now you are given this ECG. The rate is normal. The rhythm is sinus. There is no arrhythmia. I don't think there is an arrhythmia. Then what is wrong with this? There is no ST elevation anywhere. There is one peculiar wave which is here. And believe me, if you can identify the ectopic, then it is ventricular ectopic. Never think it is APC or junctional premature complex, because you will not be able to identify it. If you can identify an ectopic, let's say ki, if your first year says ki sir ectopic aa rahi hai, then it means it is ventricular ectopic. If your technician says ki ectopic aa rahi hai, it is ventricular ectopic. Atrial ectopics and junctional ectopics are more for your consultants. So this is ectopic. This is ventricular ectopic. What will you do if you get these ectopics? You will look for the cause and you will observe closely. You will look for the cause. What can be the cause of ectopic? It could be, यदि ACLS की बात करें तो it could be 5H and 5Ts. यदि हम हमारे Indian Resuscitation Council की बात करें तो it can be hit the target. So just remember the mnemonic, hypoxia and hypokalemia and hyperkalemia and all those things. So if you see an ectopic on your ECG or monitor, you have to go for the causes. And you are lucky if your examiner gives you this ECG, because then you can just explain him all the causes of ectopics and the viva will settle down. One more. Last one. What is this? Just diagnose it. What does it look like? क्या है ये, क्या है ये, क्या है ये? Is it regular? No, it is FNI. It is fast, narrow, and irregular. And what was the rhythm if it is fast, narrow, and irregular? What is the rhythm? Atrial fibrillation. If it is fast, narrow, and irregular, it is atrial fibrillation. Last one. What is this? What is this? What is this? तो बड़ा doubtful है, ये क्या है? Can somebody identify this? This is interesting. Is it fast? Good. Some people are writing the correct answer. So first we'll need to identify the QRS complexes. And coincidentally, the QRS complexes are very few in this ECG. And if we look at like lead 2, then QRS complexes and P waves are almost of the same size. This is probably one lead where you can see the QRS complexes distinctly. So this is one QRS complex, and the next QRS complex comes here. This is one QRS complex, next QRS complex comes here. This is a QRS, दूसरा QRS. So this is slow. This is very slow. When 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, the rate is hardly 25 or 30. So these are the QRS complexes. So the rate is hardly 30 and it is regular. What is your diagnosis? What is your diagnosis? Give me in the chat box. Complete heart block. या तो तुमको सब पहले से ही आता था और या फिर तुम सब एक बार में सीख गए. So this is my सचमुच की last slide. So if you like this lecture, you can write happy in the chat box. You can write whatever you want. I'm open for questions, but questions will be about exam oriented ECG. Somebody asked कि pregnancy में ECG में क्या change आते हैं, theory नहीं पढ़ाऊंगा. So we can open it for unmute. नहीं तो क्वेश्चन आंसर है ना, वैसे भी रिकॉर्डिंग से डिलीट हो जाएगा. I have enabled unmute, so you can say whatever you want, and then I think we should leave the consultants. We have already made them wait for. हाँ, pacemaker ECG तो पढ़ाया नहीं.
Thank you, sir. I think for such an elaborative and descriptive presentation on ECG, I'm sure all the delegates would have been highly beneficial from your presentation.
Thank you, sir.
I think there are only few queries.
Thank you, sir.
Yeah. देखो, pacemaker ECGs, maybe I'll make a 5 minutes video and I'll put it on YouTube and I'll share the link.
I think, sir, there are only few queries, like explain the J point and all that.
Again, like, see, I had to explain everything in one hour, na, so I just skipped a few things.
Okay, and then difference between monomorphic and polymorphic VT.
Right. Morphos means look. How does it look? How does it look? Monomorphic means monomorphic means the VT which has all the QRS complexes which look exactly alike. And polymorphic is some of the QRSs look different and some of the QRSs like big and some of them are small.
So Ashwin wants to know early repolarization syndrome.
Again, नहीं आएगा एग्जाम में, छोड़ दे. अभी सिर्फ एग्जाम की बात करेंगे. देख, मैंने ECG 10-12 घंटे पढ़ाया, YouTube पे ढूंढ ले मुझे. मैंने बहुत सारे लेक्चर्स बनाए और बहुत सारे बना रहा हूं. So in this class, what we want to make it कि एक जल्दी से एक सेरेलैक जैसा बना के खिला दें और जिसको बच्चा पढ़ के एग्जाम में दे आए. बाकी तो ECG तो अनलिमिटेड है.
The delta waves, do you want to comment on that?
डेल्टा वेव्स दिखाई थी ना, हाइपोथर्मिया में मिलेगी. राइट. मेरा YouTube चैनल नेम नहीं, यहाँ पे एडवर्टाइजिंग करना हो जाएगा. तो एंड करें.
अरे रिद्धिमा, invite Dr. Satyan.
Yes, sir. May I request Dr. Satyan, sir, to please say a few words?
Thank you. Yeah, Dr. Chaturvedi, it was really an amazing presentation. Extremely utilitarian, extremely useful for the postgraduate who would be going for the exam in maybe a couple of weeks or so. So I enjoyed the presentation thoroughly, and I'm sure all the postgraduates did it as well.
Thank you, sir. Thank you so much, sir. Really means a lot to me. And again, sorry for being late, like 15-20 minutes before.
No,
the
it was worth.
class.
It was a presentation worth waiting for. So it was. We do not regret waiting for those 20-25 minutes. It was great.
Thank you, sir. Thank you so much, sir.
Thank you very much.
Huh.
So what you
Yes,
said?
ma'am.
Any queries left? Any queries left? Just tell me, because it will be very difficult to catch Dr. Subodh again. You know.
नहीं sir, ऐसा भी
Yeah.
नहीं.
People are writing so much now, sir. RR progression, how to calculate and rate.
Sir,
and
actually,
We
ECG
will
is
have
like
we will have a
Anant.
revision class later on from with
Yeah.
Yes,
Dr.
sir. Maybe.
I think we need to have sir again next time.
Anytime, sir.
Yeah,
Anytime.
it's
anytime.
quite a very, I think, very absorbing class. Even I want to become a PG again to do those whole things. Sometimes, you know, it's very nostalgic also to listen. You know, when you were doing PG and your old days come in the memory, yeah, we should have read like that. We should have been taught like that. Those things
Yes, sir.
come to your mind. And the teaching skills are always, you know, very, very appreciative. And today's class was one of the best class I've seen in the recent times, and it's good. And I will definitely going to have a revision class from you, sir, very soon,
Many
because
thanks.
that may be required for the all the students. They're really, I think, very happy. They have shown the reaction also here. I think it is a good thing to be having people like you on the classes. I want to listen from all the people who are present here. I think Dr. Srekha Shinde want to say something first. Madam, unmute yourself. In the meanwhile, Subodh sir, kindly start unsharing the screen so that we can have a gallery.
Sir, I'm not sharing the screen. This was my
Okay.
camera only.
Okay, sir.
Yes.
Ma'am, unmute yourself. Shinde ma'am, unmute yourself. Yeah.
Thank you, Bajwa sir, for allowing me to speak. Dr. Chaturvedi sir, thank you so much. Actually, after so many lectures, this is the first lecture I'm enjoyed thoroughly. You know, I was just glued to the lecture. I'm a professor in anesthesia, taking exams for so many years. I mean, whatever you said, you know, how to test a student, I exactly do the same thing to test how safe they are, you know, as an anesthesiologist. And you just seconded it, but it was such a wonderful thing. I would like to come to you and learn everything what you can
Please.
teach us, actually, for my students. Really wonderful, sir. You are
Ma'am,
amazing.
actually, I'm running a platform for doctors and I have like 40,000 students on that.
Yeah, you are amazing, sir.
Thank you.
I'll definitely enroll myself, you know. Sir.
No, ma'am.
Thank you so much.
Thank you.
Thanks a lot, sir. More power to you, really.
Thank you, ma'am. And anybody else want to say something, they can unmute themselves and they can raise hands. I think everybody has understood very well today. Dr. Naveen want to say, you still want to understand something? Yeah, Naveen, please. Unmute yourself.
Congratulations, Dr. Subodh.
Thank you, sir.
It was pleasure listening to you in and out. And I was logged in through both YouTube as well as through Zoom. And there was more than 100 participants on the YouTube also.
Okay.
That shows that the class, this impact, and we look forward to keep on sharing your knowledge and wisdom with us in the future also.
Definitely.
Thank you.
Sure. Thank you so much.
So I think if anybody is not here to comment further, we can close this class.
Yes, sir. Yes, sir.
Yeah. Thank you, Dr. Subodh, and thank you, Dr. Satyan. I think it's a pleasure inviting you and listening to both of you. Dr. Satyan remained silent because he wanted to say
I just had one query for Dr. Subodh, if you permit.
Yeah, please.
I was wondering, how was he doing the presentation all the time? I mean, he had a camera, of course, and you had a projector on, or how did you manage this show?
Oh, sir, it is a complete studio setup.
Okay, then
maybe I'll send you a photograph personally.
That's understood, because I mean, maybe that's the complexity of it might have taken a little bit of
yes, sir.
time to
Yes,
arrange.
yes, sir.
Yeah,
yes,
but it was very interesting. As looking at the whole thing and how the chat was coming on, so I understood that it's a studio that you're presenting from, not from. Excellent.
Thank you.
Thank you. Thank you everyone for joining today. And for the next class, we will be having on aortic stenosis. So I think you can come prepared with aortic stenosis, and whosoever, all the listeners, you can tell your friends, they can send a request to official number of the ISA NHQ. It's given on the website, so that they can also join into the WhatsApp groups where they can receive the links. You can see the live streaming as well as you can see the recording later on the ISA NHQ YouTube channel. So all the classes are available. Past classes are also available. This class will also be available by tomorrow. So I request everyone who wants to join the WhatsApp group, they can send a request to the WhatsApp number available on the isaweb.in. So in the future, they will be receiving the in the group. They will be added in those groups wherever they want to get added. So this I say thank you everyone, and thank you Ridhima for anchoring this show.
Thank
And
you,
I
sir.
think it's time to leave the thing because it's quite a late. I think 8:15 going to be 8:15. We will meet next time for the aortic stenosis class, and we will be waiting for a revision class from you, Subodh sir, later.
Thanks. Sure, sir.
Thank you very much.
Thank you.
Good night, sir.
Long live ISA, and with this we close the class.
Thank you.